Finance Committee will come to order, please. Any citizens who would like to address the committee this morning?
We do not.
We do not? Okay, all right. We'll move on to approval of the minutes from the June 22nd meeting. We have a motion for approval from Dr. Wepper, a second from Ms. DeBose. Any questions? All in favor, please say aye. Aye. Opposed? Motion passes unanimously. CFO report, Ms. Clark. Oh, she just stepped out. All right. Well, how about a musical interlude? Robert's going to sing some songs.
She better come back. She better come back quick. The funny thing is, she said, I'm going to sing, and JR wants to.
Well, and I would like to hear JR, actually. So we'll wait just a second.
There's Ms. Clark.
There she is. Yay. So item number 4 is our CFO report. And while our CFO gathers her materials and comes to the dais, we will watch her.
Yeah, I know.
Oh, I know. Good morning.
Good morning. How are you?
We are well, thank you. We're just hanging out, waiting for you. That's all.
Thank you.
CFO report, please.
I have 2 items. It is not. Sorry, I usually have a little flat one. The quarter ended June 30th report is available on the portal. It is in the libraries, the investment tab. And if you have any questions, feel free to give me a call on that. There's not anything unusual in that report. The second report I wanted to give you was a little update on budget 18 and also where I think we might end up for projected 17. But after thinking about it, I think that report fits better after the June 30th monthly results. So if you'll indulge me, I'd like to do the June 30th month result and then go over my 4-page PowerPoint after I finish the June results. So I think that'll just flow better. So. Okay, if we're ready? All right. So going into June was a difficult month financially for the hospital. The top side, and I'll just talk a little bit before I actually get into the slides. The top side of the financial statements, the revenue components were strong, and we'll go through the volumes here in a second. What made it a difficult month from an operational financial component was some of our expenses. There were a lot of things that went on. We had some prior months expenses hit in June, and then we just had some unusually high expenses in June. But when you look at our admissions, our inpatient and our outpatient volumes were pretty strong. Our admissions were 9% over, and our patient days were about 7%. And the CMI, which tells us the acuity of our patients, were down. It was down just slightly by about 4%, and our length of stay was down to complement that as well by about 5%. Also on our outpatient side, you can see for the first time our emergency department was slightly below budget. I will point out that our budget was about 11,000 visits, which is really a very high budget We have been above 11,000 before, but our actual visits were 10,261, which was a little over 342 visits a day. Down on the bottom graph, our urgent care visits were above 6% over our budget at an additional 162 visits a day. Total clinics were 2% over. We saw over 61,600, and that drove our total outpatient visits to be about 3% over for June. Other key stats that we look at, observations were about 3% over. Invasive lab cases were the highest to date. We had 700 invasive lab cases in the month of June. That was about 17% higher than we expected. Down at the bottom, both inpatient and outpatient surgeries were down slightly, 3% under and 1% under budget respectively. And then on our psych, patient days, even though the little box is red, we were actually right on target. We were only one patient day below budget, so we were right on budget. Our clinic visits were 7% greater. And I do want to point out that the psych ED has kind of returned to the normal level that we saw before the last 3 months where we were so great. And I want to spend a little bit of time on the psych ED. If you recall, this is one of the components that has been driving our purchase service expense for the last 2 to 3 months. And you're going to see when I cover June, another really high month for outside medical services. Note that June has returned to normal levels. We had really high levels in March, April, and May. We're still paying invoices from some of that surge. We might likely see some invoices still coming through in July as those patients exit those facilities. Hopefully, those will remain at normal levels for the last quarter. And then our partial hospitalization days were down significantly in June. I don't know if it was the summer months, but we just had lower patient volumes for those extended outpatient visits. Our adjusted patient days continue to be favorable. Our target is 5.96 for the year, and this is a year-to-date look. When I cover the monthly financials, I typically talk about how we did just for that month, but this is cumulative for the 9 months ended June. 5.96 compared to 5.89 FTE per APD, and that is total paid. And then on our rev cycle statistics, our days cash on hand remain at about 289, and our net days in AR is at 51 compared to 53 last month. Again, our payer mix doesn't change much, but it's always good to look at. And our connection enrollment continues to have some net additions. This month we increased by almost 300 enrollees. Looks like we're going to normalize at about 40,000 members for the year. So as we look at the income statement, the net patient service revenue, again, compared to budget, we had strong inpatient and outpatient volumes. Our inpatient revenue was about 2.6% above budget. Outpatient was 2.7%. Most of the 1.1 million overage was due to volume, about 2/3 of it. And we had a favorable price increase of about 400,000. So we're doing a great job in the rev cycle. That offset the waiver, and so the top side, the other operating revenue, was favorable by about 377,000. Salaries was over by about 396, but when you look at what we had to do for our volumes, our FTEs were at 5.75 FTEs per APD compared to a 6.04 budget for the month. And, you know, again, with our benefits line item, we did have another month where we had extraordinarily high claims volume with our employee health plan. So that's about the third month in a row where we've just seen higher than trend for the first 6-7 months of the year. So in purchase service, we've not seen purchase service be over this high for 1 month through this fiscal year. We were $3.6 million over in June. And there's really 3 components, and I'm going to try to break that out for you in a couple of different ways. So you'll kind of stick with me for a minute. I'm going to explain it one way, and then I'm going to go back and explain it a different way. So if you look at what is running through purchase service, kind of the 3 subjects, outside medical services was extraordinarily high. The first component of that was for psych. We paid about $670,000 again for the month of June, above budget. We saw that in one of the first slides because of the Psych ED, kind of the blip that came up from the prior month. And so all of those invoices are continuing to come in and get paid. We also had a large amount of home health and hospice invoices from prior months. And these were invoices that had accumulated. We were going through them very carefully, and they related to care from February through May. And this was some of the prior month that I was talking about. So those the total of those were $780,000. Now, they didn't necessarily belong all in June, but they do relate to fiscal year 17. So year to date, the number's correct, but it didn't necessarily impact the operations for June. So a large part of that 3.6 overage probably belonged in a prior month. Now, we've caught up on that home health, and what we were doing was we were auditing that. Some of those we didn't pay, but the ones we did were truly ours in appropriate care. So now that we've caught up, we expect that spend to be probably about 150 to 180, and we'll continue to process those on a timely fashion. So outside medical services was about 1.4 million of that overage. We also had our 3 major outsourced services, lab, Carter, blood care, and the pharmacy. And some of those had prior months in them as well. Lab is at a trend of about 250,000 over. However, we paid closer to $800,000 in lab this month. So there was some additional services that hit as well as a prior month invoice. Carter, we paid 2 months of services. So instead of closer to $180,000, we paid $380,000. And we're recognizing, this is all that hit in June. So I'm going to give you a prior month total here in a minute.
Okay.
And then Maxor was not budgeted, and that was about a $200,000 amount. So we have paid close to almost $1.8 million to $2 million that should have probably been recognized in a prior month, all in this month. In large part to those prior month invoices for the purchase service and lab and Carter, and then and outside medical services as well. And physician claims, because of some of the patient volumes that have gone through, were about $500,000 over. So that all adds up to close to $3.5 million. Our supply number, almost all of the supply number relates back to pharmaceutical and drugs. We had, because of the mix of the inpatients that we have in-house, if you recall, we had about 7% higher inpatients in-house. A big part of that is also the outpatient pharmacy and just what happens to walk in. We had some hemophilia patients, which are extremely high-cost patients in June, and our drug costs were just high this month, so due to patient volume. So if you look down at the bottom line, our loss from operations was $4.9 million compared to a $800,000 budget. And again, part of my second report is kind of a recap of where we think we're going to end up the year, which is a good segue to our next meeting on August 10th. A big part of my Budget 18 presentation is kind of the starting point of where is projected 17, and that bills to Budget 18. So if you have any questions about the monthly performance, I'll be happy to answer those. But I am going to go over a slide that hopefully kind of walks forward where I think we're going to end up the year September 17.
Any questions for Sharon on the? Yes, sir.
The number of admissions stayed about the same. The case mix index stayed about the same, but yet we're on the third month of markedly decreased length of stay, which is one of those indicators that CMS and everybody else looks at. My question would be, are we driving length of stay just because it's the appropriate thing to do? Or are we pushing patients a little quickly out the door to try and meet the length of stay metrics? I don't know.
So our case mix was down 3.8%,
Yeah, that's not very much.
and our length of stay was down 5.3%. So for the month, to me, those decreases compared to budget are complementary for one another. I'm not clinical, so I cannot answer the question you're asking, but it's not, they're both at least tracking similarly for the month of June.
For June, but the trend on length of stay has dropped for the third month.
It depends on how you look at things, Chuck.
Could you turn your?
It depends on how you look at things. If you're looking at Medicare because of DRG, if you can move down the average length of stay, the margin's bigger. But if you run your own, you administer a plan, then it may not make that much difference because you have to look further out do you keep them to acclimate them to go home, or you discharge them early and they end up in some sniff or somewhere? And that may end up driving the cost a lot higher if you don't look further down, so. It's a hard question.
Do we measure readmissions to know that they're
Well,
coming back?
We do, I think we measure readmissions, but I don't know how it's all correlated. Patient, I mean, do they go home on day one and then they're admitted,
Because
readmitted on 14?
Post-discharge and pharmacy is going way up if we're not careful, if we're not watching for those.
Sorry, what was the question?
Say that again, DT.
If, the cost for post-discharge and pharmacy is going up, it trend to go up, so we may have to, some point in the future, look at that to control the cost, the total cost of care.
Yeah, we look at that every month at P&T, and it's always been a struggle with, especially with the outpatient. The problem is, we got more patients coming, and the cost is getting worse and worse. And
What's getting worse and worse?
what we were being charged for the drugs. I mean, especially, we thought with generic, it was gonna get cheaper, but what the companies figured out is with drugs that aren't very, used very often, they can charge an incredible amount of money. And that's become a real, I think it's gonna be a national crisis at some point.
But some, depends on contracts also as well, because sometimes you can't buy generic because you're locked in.
I mean, we discuss it at length at P&T every month, looking for where we can save $1. But it's a real struggle.
Shannon, are you looking at, on these numbers, are you looking at, I guess, paid claim? Is that why it's go up and down?
For
Kind of
the
unpredictable.
case mix index,
No, for the dollar amount that we pay more, we spend more money. Is that based on claim coming
I'm
in?
not sure what Bill's should.
none of these, for which dollar amount?
Oh, when you said, we had more than expected, we spent more than we expected on certain area. On pharmacy and on other stuff.
Those are just gross dollars,
Gross
it's
dollars.
not per claim. And so,
Should we start looking at the RBNS number, so that give you a little bit further out?
RBNS.
Wow,
Okay. You email it to me.
it's more,
Email it to me. Okay.
we can, to address the year-to-date case mix index and length of stay, interestingly enough, we are right on budget year-to-date for both of those numbers. And you probably know that from sitting on the quality committee. Not much variance at all.
the RBNS is for report but not settled claim, so that you can see a little bit further out as it reconciled and settled, and you can, so that you can have a little bit
So-
leeway.
We can look at from a reimbursement standpoint, but I think when I was looking at the cost, the drivers of where we were at for June, I think the cost of the drugs are not always necessarily, there's not a tight linkage between what's going on in the income statement with the cost of the drugs versus how we're getting reimbursed for those drugs, especially on the inpatient side. But we can talk afterwards and see if you have some ideas.
I wonder if, with the particular type of patient that we usually end up with, should we start looking at MTM, the medication therapy management and all that stuff, trying to see if we can bring that cost down over time? You know?
Well, from a medication therapy perspective, we've just added several clinical pharmacists over the course of the last, it's on, I'm sorry, I just need to talk louder. We've added several clinical pharmacists over the course of the last 18 months, and that's an issue they're addressing,
Right.
right? Specifically, and I've missed some of the dialogue, I couldn't hear, but to your question, Dr. Weber, about length of stay, managing to that, It's always been a factor, but it's not the factor. We're cognizant of that issue, but the majority of our patients aren't necessarily reimbursed on a DRG perspective. So we're not managing those folks out early. I know the ED volume is down for June, but when you have patients, and we had several days in June that we were boarding 40 and 50 patients a day, then there's an emphasis to clear the way for those patients to occupy the beds. So I don't think we're discharging anybody that's not ready. In a perfect world, might they have stayed longer? I can't answer that. It's a speculation, but I can specifically answer we're not managing patients out just to length of stay. We're not. Won't do that.
I did not want to imply that that was what was going on. For me, it was an observation.
Sure.
In which case, if case mix index is about the same, patient volume is about the same, if length of stay is driving down, that to me means everybody's getting a whole hell of a lot more efficient in their patient care. There's no delays in testing, et cetera, so they can get out earlier. Then the only metric for me to look at would be, are they readmitted within 30 days?
Right.
And if they are not, then everybody deserves 5 gold stars
Right.
for the length of stay going
Exactly
down.
where we want to be, right. Without the
No, that's what I
readmission,
wanted to get to, but I just,
Sure.
without the readmission data, that's kind of hard to.
Right.
And we're tracking that. I just don't have that at my fingertips, what
well, I
that
know
is.
Frank has to look at
Right.
the 30-day readmissions and all that kind of stuff.
We track that consistently, right.
I think that's also one of the things that maybe ought to appear briefly on the acclaim
Sure.
budget document.
Add that metric, yeah.
Okay, great, thank
I
you.
would think that when you talk about your home health visits and hospice visits, as the patients are being dismissed, we are doing more home visits. And I don't know if that's true or not, but it seems like with your dollars that would also impact when they go home early. You're doing some home visits on it.
I did have, one question I had with that is, are those JPS connection patients that we're talking about?
They're not just the connection, they're unfunded patients.
Unfunded as well, okay.
Yes.
Right.
Thank you. Any other questions for Sharon?
Thanks, Bill.
Thanks, Bill.
Okay, so we're gonna talk about a claim. So from an encounter standpoint, a claim ended up, I believe, at about 11% under budget for the building counters, which is close to their trend. You can also see monthly encounters by department on the bottom left. Again, and the pie chart shows kind of the physicians by their specialty, if you're interested in looking at that. Now, a claim on their income statement theirs looks pretty normal to their trend for the last few months. Their net patient service revenue did show 15% underage on the month of June, which tracks with their encounters being under 11%. They did have lower inpatient encounters, which typically count a little bit more of the dollars. So the 11% translated into the 15% for dollars there. And there was some vacations taken in June. Now, there are 2 big variances in here that actually wash out on the bottom line. And the other operating revenue, you see a $2.8 million variance, and you also see a $2.8 million variance in a purchase service cost that net out to 0 for a claim. if you recall, back in February, you approved a surgical services contract that was assigned from the medical center to a claim. And that transaction occurred in June. So we recorded the February, March, April, May, and June months in June for that contract. So the payment from JPS to a claim was recorded here, and then just from an accounting standpoint, the expense of that contract from a claim to the surgical group was recorded here for those 5 months. Although it was effective in February, the contract was not executed until late April, and it took a couple of months to get through that process for us to record it. So you'll see that coming through for the last quarter in a claim, and those assignments, again, were not budgeted in a claim, so there'll be a variance each month, but it nets to zero on their bottom line. So that was really the only main budget variance for them with the open positions. And their income, their loss for the month was $1.4 million compared to the $738,000 budgeted loss. So not anything unusual in a claim.
Questions for Sharon on claim? Did you want to review the combined, or is it?
Oh, I sure can. So when we look at our combined June, dropping down to net income, we've already kind of talked about the month. The year-to-date net income for the hospital, $3 million, 70,000. A claim is at a loss of 12.6 million. So our total is a loss of 9.5 million for the district.
Any other questions for Sharon on the financials? Do you want to go over your 18, or
Yes.
your final part of the
Yes.
current 17?
Yes,
Sorry.
I'm gonna go backwards to my CFO report. So you don't have these slides in your portal. So kind of jumping back to the fourth quarter results, we just covered the operating loss through June at $2.8 million. If we go back and we look at where volumes have been and where our expenses have been, the quarter ended September 17. For the last 3 months of this coming year, expecting, higher outsourcing costs, the employee benefits trend, not necessarily where it's been, but continuing to be slightly higher than budget, and our outside medical services, again, not expecting psych to be where it has been, but I do expect it to be high in July, kind of as we ramp down, hopefully. We know that our hospice and home health invoices will continue to come through at about $150,000 a month. And if you recall, we have begun to outsource our SNF patients. We approved that contract last month, and those will be about $150,000 to $200,000. Now, from the SNF perspective, we've reopened T9, and that's allowed us to have a whole nother inpatient floor. So we're getting the revenue from those patients. That'll be increased inpatient volumes for us. But all of that being said, we could potentially lose about $1.5 million a month. That's a high-level projection. That's not our goal. That's a possibility. The next three items are really a high-level estimate as well. There's a lot of moving parts in our supplemental funding. Through the process of Budget 18, and I I really don't want to have to talk about uncompensated care for budget 18, but I'll get into it again. And the infamous $10 million that we lost in 16. And we've been accruing $10 million less. The $833,000 that you see is the deficit each month this year, because we don't want to over accrue. You know, the actual payment that we received in 16, because of our slice of the pie, got smaller. In working with our consultants, what we're projecting for 17 is that the large public pool will actually shrink just a very tiny bit. But they believe that because our UC costs have increased, that the JPS
Slice
slice
will be
the
bigger.
pie will increase slightly. And that based on what I have been accruing this year, we could receive $3.6 million more in September. So, I've written that down and I've put it up on the board. But we're not going to know until September, when all the other hospitals formally calculate, turn in, and the state notifies us of what that final UC number is. So that's a big estimate.
And this is Spivey telling us that he thinks their
This
UC
is
is
Mike
gonna be
Spivey
3.6.
running the very complex models that they run. The big risk there is there are, I believe, 2 of the large hospitals that they do not have detailed UC cost calculations for. So there's some pretty big estimates in that number,
Okay.
is the qualification.
But that would be booked for 2018, right?
No,
We'll see in
this would be
September.
2017 numbers. We would find out from the state what our final UC calculation would be in this current fiscal year for 17. Now, for fiscal year 18, when I present my budget, I'm booking the higher number for 18. So I'm including the higher number that includes this $3.6 million pickup for 18. I've assumed that we're getting the larger piece of the pie for my budget, which is a budget assumption. So with the information that we know, we are slightly better for 17 and 18 than we ended up for 16 by about $3.5 million.
Is that gonna give us enough cushion just in case they switch to a block grant for Medicaid?
I have not budgeted anything in case we have any major changes in Medicaid. If there is a large change in Medicaid, or we'll have to go back and rethink. You know, a budget is a plan based on what we know. If something major happens with any of our governmental payers or any of our supplemental funding after budget happens, my recommendation is that we go back in and just revise our budget plan. I cannot create a budget that has that large of a contingency at the departmental level and have my managers and directors try to plan for something like that. So the potential DSRIP achievement, we have 2 things going on with DSRIP right now. We've had a really good experience with our achievement for the current year, and we're also working towards items that we were not able to achieve in a prior year. So about half and half of that $6 million is for things that we think we're going to achieve above and beyond for the current year, and things that we can go back and get from a prior year. So that is a firmer number than the UC. We also think that we may pick up about $600,000 in dish by the end of the year. And the tobacco revenue settlement of 2.7 is actually cash in hand. The tobacco settlement for 16 was very low. The state had kind of run out of funding, may not be the right terminology, but the tobacco fund was very low. In 17, they took some money out of the discretionary fund to supplement it, and we had budgeted it at the lower number. So this year, we got $2.7 million more than budget. We did get that check. It's sitting on my balance sheet. We were working through some dish calculations. I was afraid that we were actually going to be short on dish, and it turns out that we're going to be about $600,000 favorable. So we do have 2.7 on the balance sheet, and that number is firm. So it is firm. We have that cash. So the 2.7. So yeah, so to run through, you know, we are at a $2.7 million loss for the year. The 3.5 is just kind of an estimate with a lot of moving parts for the quarter ended September. If we could end up at a break even, that would be a great achievement. The summer months are a very difficult time for healthcare or a hospital to break even. The supplemental funding on the next 3 lines will not really settle till September timeframe when the state sends out those final notifications. And the tobacco revenue settlement we actually have in hand. So we may end up the year at about a $7 million margin. To remind you, we did budget $13.7 million. So that's kind of where we are right now for the medical center. Do you guys have any questions on that?
Any questions for Sharon? Okay, you want to talk about 18?
The 6.9 is what you will see in the budget presentation as the medical center's projected on August 10th. So for budget 18, these are kind of the large items that I'll be talking about in a couple of weeks. As Bill and I have tried to lead through budget, 2 of the major things that you will hear is that we are really focused on the rev cycle and making sure that we have the right care at the right time at the right place. Over the last few years, we have focused on expense control. And to be quite honest with you, there's not a whole lot of expenses left to cut at the departmental level. We have done a good job on rev cycle over the last 2 or 3 years. However, there are pockets that we have specifically focused on, meaning small areas of very targeted focus that I feel like if we change this process and drill down, we can find very specific denials that we can overturn or prevent. And that's what we've done here. It's not just, well, you know, we have $5 million worth of denials and I think we can pick up $2 million of that. That's not how we've done this budget. We have talked about some of those with you as a board last month, and we're gonna make some changes around some of the OR scheduling issues that we talked about in closed. So some of those revenue cycle opportunities and denials management, we're gonna focus on charge entry. And this is a hospital-wide thing. It is not, you know, just an area it's not just finance, it is in our outpatient clinics, it's at registration in the ED, it is in all areas. We're bringing new software today for approval that we think will improve accuracy. So there's lots and lots of focus on what we can do, again, on the top side. One of the major areas of focus is also in utilization and care management. So we're gonna ask to add a lot of resources in case management to ensure the appropriate level of care. This will also help with denials management. And we'll get into that, the more specifics on the 10th, but that's probably one of the biggest asks and one of the biggest targeted focus. Some of the increased services that we're adding is urology. That contract has come through. That's gonna add some volumes throughout the house. And we've also increased invasive labs. You've seen that. We had our highest month this month ever. T9 has just reopened, and that has a large impact on our patient days. We've been able to fully staff that, and it will fill up with patients.
I don't remember what T9 is, that med-surg?
It was the old SNF.
Right, but it's now what?
It's med-surg.
Yeah, okay.
Yes, sir.
Gotcha.
On Tuesday, we did get our certified tax roll. It will produce a $35 million increase, similar to last year. It's about 9%.
Sweet.
The productivity engagement, we have budgeted for that to make sure that we have adequate labor levels and ensure the standard of care. One other major assumption is that as we move our district projects, it's kind of a fruit basket turnover. So as we move from DY6 to DY7, that change did not line up well with our budget timing. So we are making the assumption that district will be budget neutral. As we go through that planning, we'll have to, post-budget, make all of those changes. So you'll be approving a budget that district is kind of status quo. And probably late September, we will be making departmental changes, but it will not impact the bottom line. So from DY6 to DY7, there'll be no change to the bottom line for our district projects.
Sharon, when you say you'll be making departmental changes, that's.
So a lot of the metrics and a lot of the changes that the metrics are not gonna remain the same. So we're gonna be moving things around. For example, it's easier in a claim because there's one metric in a claim. So the claim metric is going to be changing from pain management to cancer screening. And so we're able to get that change. You're gonna see that change in the acclaim budget when we talk about the acclaim budget. But we have, Wayne's probably gonna shout something out behind me, but we have 27 some odd metrics that are flowing up into, it's a page with, he's got it all color coded for us. And as we start to change those,
Here comes your help.
it's not going to.
I gave you a wrong number, so I gotta come in clean.
Okay, so I was like, I thought it was more than
We have
that.
55 measures. Right, currently today, we have 27 projects that have probably 3 to 4 metrics apiece. We're transitioning to measure bundles. Those measure bundles will range from 3 measures up to 5 or 6 measures. A total right now, for the whole system will be around 55 individual measures that are a part of.
Wayne, hit your mic so Sharon can hear you.
That are a part of, yes, sir.
It's so cool.
55 measures that are part of about 8 or 9 measure bundles. And so that shift in some of the measures that will fall off and some new ones that come on, we have a lot of very talented people who are doing that work, and we anticipate that most of that will be shifting their focus, perhaps realigning some of the activities. If we're doing some things today that don't help us meet those new metrics, we may need to redeploy those resources and that programmatic stuff so that it better does that. But as Sharon said, we're just not in a position right now to have enough clarity on that to try and make those changes in time for this budget process.
We typically, when we bring the budget to you, we have locked down departments and there is no movement. For this, we are actually gonna be creating new departments, and we may shift some purchase service to supplies or vice versa. We may be moving people from one department to a newly created department. We may be, they're shifting. And we typically don't have that shifting after the Board of Managers has approved a budget. But we're gonna be asking for that flexibility. It will not impact the bottom line. And then from a capital standpoint, one of the major strategic items on there is the design of the outpatient surgical center that's gonna be over by the pavilion. So that was an important factor. On the acclaim side, we have, oops, I missed it. On the acclaim side, we have talked about this before, so I think this will probably go a little bit quicker than the medical center. Year to date, we're at the 12.7. The fourth quarter, we think it's gonna be about 4.9 million for the 3 months. During that last 3 months, we're bringing on 35 new providers. These are people that are already in the pipeline. And then that's gonna be offset by about 2.1 million of adjustments that, or dollars that JPS is going to be funding over to acclaim. We've talked about that. Those are mainly for reconciliations for funded specialties, budgeted items that were on the medical center that have now been transferred over to acclaim. We just need to bring those dollars over to offset those expenses on the acclaim books. And during the Jay Taylor presentation, we had talked about that 2 million. And then just to kind of bring it full circle, Jay Taylor had talked about the 14 million. And then when you add in those 2 reversal items for GME and the coverage expense, that brings us back to the 15.5. And so we're right there where we had talked about being. So I just wanted to tie those 2 presentations together, my 15.5 and the 15.5. Y'all have any questions?
Questions for Sharon?
When this comes to a claim, could you break out what the or who the providers are?
We certainly can. The new ones that are coming on in the
Yeah, I mean, are they
last quarter.
physicians, physician assistants?
Sure,
Okay.
we sure can. Acclaim budget, and just so you said that, the Acclaim Executive Committee will be seeing the Acclaim budget and hopefully approving that on Monday. So we can get the full budget to the Board of Managers on August 10th. So, yeah, we'll have that for you on Monday.
I have one other one that is not on here. We used to talk about third next available clinic, and we have not done that in a long time. And the reason I'm bringing it up is we're bringing on 35 providers, we've heard. Sure, that's a good question.
It is a metric in our annual incentive plan.
Right.
And we review that quarterly. And historically, for this year, we've not been at the levels that we anticipated, but in the last month, we've made significant progress, and we're managing to the providers that we have, and the additional providers we're bringing on is going to further enable us to move along that path. Last information I had, we had made significant improvement in third next available.
Great.
We'll bring that back to the
Once
quality
again,
committee.
It's something that
You bet.
they don't get credit for, but they should, for bringing that down. And coming with that should be
Agreed.
increase in patient satisfaction
Sure.
scores.
Sure.
I mean,
Keeps them out of the
but
ED.
I just thought it'd be something, once again, that we could look at very briefly at a claim.
Yeah,
Maybe on Monday if you can get it by then, if not, the next month.
yeah.
We can do that. Great,
Okay.
excellent, thank you.
Thanks for your question.
So the acclaim budget, and that's a really good segue, it's focused on onboarding providers. I was going through the presentation this morning, and most of that 15% growth in encounters is in primary care. So, that focus again is to try to help us achieve that third appointment. Again, talking about the focus on those assignments of the contracts from the medical center to a claim. They're taking urology, neurosurgery, and the surgical services along with the chief of surgery. Their district metric, as I mentioned before, is moving to cancer screening. That's going to provide them with additional revenue for the year in the DY7 timeframe, which is fiscal year 18. Services for 2 new MHMR behavioral health clinic locations will be included in budget 18. Those will be fully funded for a claim, but it is 2 new locations. The new comp plan is fully phased in by January 18. They're going to realign their HR function to make sure that they have stronger recruitment and employee retention. And there's going to be some savings by insourcing the contract review function with an in-house legal counsel proposal. So that's going to be some of the bigger changes for a claim.
Where are the 2 new mental health clinics? He's sneaking up.
Yeah, I had that written down, and I don't have that with me.
I'm just curious, where are the 2 new ones?
There's one that is at MHMR's clinic location that's on Lancaster. So we had been operating out of that before True Worth opened up, and they really appreciated the collaborative nature of the care. And so they're funding a primary care team to be at that clinic. And then the other one is at their clinic that's on Circle Drive.
Circle.
Which one's on, did we not have it on Circle Drive before?
They have a mental health clinic there, but we did not have an integrated primary care clinic in their mental health clinic. We have a clinic over on South Campus where we do physical health care, but it's detached from, so they're trying to create a kind of medical home, if you will, within their seriously mentally ill clinic that they operate. And so
Okay.
they are contracting with a claim to provide physician services in their mental health clinics.
Okay, great, thank you.
Yes, sir.
So that's the end of my preview, unless you guys have any other questions.
Any questions for Sharon on the preview?
It's like the trailer for the big movie coming.
Less exciting, but
Planet of the
Yeah,
Apes.
yeah, no car chase.
Thank you, Sharon. Before you depart, I need to get approval for the acceptance of her June 2017 audit.
Recommend acceptance.
Dr. Wepper, second by Mr. Nguyen. All in favor? Yes. You have a question?
No, I'm gonna wait till I do vote.
Okay. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you.
Mr. Chairman, only question I have, and I know that Dr. Weber had some questions, he chairs the acclaimed executive committee. They will see this budget, or the proposed budget at 2:30 this coming Monday. There is not a finance meeting nor any other meetings prior to the scheduled board of managers meeting, if my memory's correct, on September 10th. I'd just like to, I think hopefully Chuck would concur to.
August 10th.
August 10th,
August
but I'd also like to open and say, Mr. Chair, if you're available at 1:30 on Monday afternoon, I think that's when the acclaim.
2:30.
Is it 2:30?
Yes, sir, and I've been invited and I'm accepted. Thank you.
Good.
Thank you.
And
Oh,
I
yeah.
would say anyone else of the finance committee that would like to be there to attend that meeting,
in view of the fact that the entire board's gotta get up to speed and make sure if
Sure.
there's any other questions prior to the August 10th. So again, I appreciate you already accepting that, but I'll extend that to any other finance committee members, Chuck, if that's,
He can chair it.
no, Chuck, you're chair.
We're not voting on that one.
Thank you. It's scheduled for 2:30.
No, anybody's welcome.
Yeah, 2:30
Please.
is coming.
Okay. We'll move on to item B. Thank you, Sharon, on that. Oh, and you're still here, and Katie's going to join
For
us.
a while.
Good morning, Katie.
So, the contract that is in front of you is for Experian Health. This is, a software that is replacing a current vendor. It did go out through RFP. It is budgeted, and not only will Experian provide us with, a lower cost, a savings of about $100,000 a year, but it does provide us with newer technology, and it does integrate with Epic. And this is one of those things that we did budget a bit of incremental revenue from. It's a really great add-on. This actually goes out and validates addresses, insurance verification. It allows us to check the quality assurance of our registration folks, and it can also go through and automate registration automation and double check to make sure that with Aetna, United, and some of the bigger carriers, almost all of the bigger carriers, to go out and
Right.
pre-cert.
Got nothing to do with the three groups, the credit ratings, Experian,
Oh, no,
not a
no.
branch of theirs.
No, this was a company, when I used it before, and there's probably 3 to 4 big insurance verification companies out there. It was the old Passport. It had been known as Passport before. There's a couple of mergers that have happened throughout the years, but currently the group is Experian. And this was the recommendation of the group. It was the low cost as well as the high functionality bid.
The old Search America.
Okay, heard explanation. Any questions for Katie or Sharon?
I have one question. Under your maintenance, is that really the transaction expense? I could figure out when I looked at it, the implementation cost, the subscription cost, and then I saw the maintenance, but is that just the
Yes,
transaction?
we're contracted for a certain number of transactions, and if we go over, then there's
Okay.
like a penny charge.
So per click.
Thank you.
Okay, you've heard the description. Any questions? Entertain a motion.
So moved.
Motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed, motion passes. Thank you, Katie. That was very well presented.
Sharon did a great job.
Yeah.
Item C.
I've got 2 managed care contracts today. The first one is with United Health. This is a new product that will be offered in 18 in preparation for new bids that are occurring in Tarrant County. They would like us to be in network for their CHIP and Medicaid product. So if they were to win the bid in Tarrant County, we will be listed in network for their product, their Medicaid and CHIP product.
Good. Okay, any questions for Sharon? Entertain a motion.
Move approval.
Motion by Mr. Bose, second by Mr. Nguyen. All in favor, please say aye. Opposed, motion passes. Thank you. Item
The-
D.
Yes, the second one is so exciting, Wayne may want to come back up. This is the Magellan Psych Behavioral Health. We have quite a few of these patients that are currently in-house, inpatient and outpatient. And This is for commercial, Medicare, and Medicaid products. This is the first time that JPS will have a contract with Magellan. And this will be a very good move forward for JPS and Magellan.
Absolutely. Any questions for Sharon on this? Motion? Motion by Mr. Powell, second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Thank you, Sharon. Mr. Early, item E.
Mr. Chair, I'd like to ask if Dr. Melissa Acosta could come up as well. And let me, for those of you who have forgotten maybe at meeting Dr. Acosta, let me introduce her again. She's our Director of Clinical Research. And right now, Sharon Clark is her best friend because she's trying to figure out how she can catch her plane out of here because she and her husband are going to Cooperstown to watch Mr. Jeff Bagwell be put into the Hall of Fame. I don't know why anybody would go see an Astro put in the Hall of Fame, but there are rare occasions, so I think you got to catch him when you can.
The second one.
But we really think you're going up to see Pudge Rodriguez, and that's what we're really impressed with. But Dr. Acosta is formerly from the Baylor Research Institute, and we've been proud enough to have her part of this organization, and she has made some significant benefits to us. What we have today is a collaborative effort to establish a collaborative community IRB. I would tell you at the beginning that none of the research that would be conducted at JPS would be done without the approval of JPS. We maintain complete oversight over all research. The second thing is, and we've met with the Education Committee and others, Mr. Wynn, Dr. Weber, Mr. Bose, and others, to describe this in 2 previous meetings and go through some details about this and trying to outline some of the things that we were trying to do. We had brought in a third party and found that we had some issues with our IRB that created some compliance issues for us, and an answer to that is this effort to create a community-wide IRB. It is established in an effort to create that. You are going to see a heavy part of that being UNT at this time because UNT has an IRB. We do not think that this is a JPS UNT IRB. Even though it will look like that on paper at this time, it is our interest to create a collaborative effort in the community with not only UNT, but ultimately TCU. We have had some discussions with UTA. We have had discussions with others in town that we think could bring their efforts for research to the table, such as Tarrant County College and even Parkland, as Parkland struggles through some of the issues they're struggling through with their IRB. I've had the luxury of talking to some of y'all with very legitimate concerns and questions about this, and I think we're going in the right direction. Establishing new community collaborations is challenging. I just had a meeting, Mr. Powell and I just had a meeting earlier in the week with one of our county commissioners emphasizing the need for a collaborative effort to what you do in the community, and forging those new collaborations not only is a new road, but can be challenging in attempts to do that. So I think there are benefits to this. I do think and firmly believe that JPS has total control of our research and always will. Dr. Acosta, if you want to add anything to what I've said, you are more than willing to do that. And then when we get into the question period, if I can't answer them or Dr. Acosta can't answer them, we also have Dr. Rosinia and others who potentially can as well. But if you want to add anything that I missed, I'm happy to have you do that.
Yes, I would like to add that the establishment of this collaborative IRB will be the tipping point for JPS. I mean, JPS can establish themselves as a hub for research within North Texas and the rest of the community.
Thank you.
So I'd just like to put in that plug.
I know that, and I will say that my discussions with Ms. DuBose have been very positive in her attitudes to try to figure out what we do and how we do it, and I respect that very much, and we've had some nice discussions along with Mr. Wynn. So, Ms. DuBose, some of those questions, if you would like to ask them now, I think it'd be very beneficial. So one, we either get clarity, or two, help define where we'll be on this.
One of my questions is.
Is your mic on?
I'll start by asking, when we do this IRB, how is it affecting JPS Research Institute? We talked about that. We've had no report on it, so that was one of my questions. If IRB is going to be done there, how will this affect our JPS Institute?
Actually, it will make the research, it will make it more efficient and increase compliance. Currently, to establish a research project on the premises of JPS, it is time-consuming. If you're doing a multi-site study, you have to go through multiple IRBs. This would eliminate that redundancy and just increase efficiency and also increase compliance.
Second question, based on the contract, you have a couple of folks listed in there as a part, 25% executive director, a director, and some staff. Is that JPS staff?
The staff would be UNT. However, there will be a combined IRB board and a combined oversight committee. So there will be equal representation from both JPS and UNT on both board and the oversight committee.
Okay. I saw the oversight committee, and I did see that we had two, but then I see that's listed is that is a report directly up to the president, CEO of UNT. I do not see in the document where there is any dotted line for this collaboration. You know, it's all, if you look at it, it's a straight line over there. We are putting in monies, which, for, I mean, $300 and some for this, but it's all over there, reporting up to their board. JPS is nowhere there except sitting on this oversight. I find that to be a little troubling if it's a collaboration. That's one of my issues on that.
Well, just to address that issue, the oversight committee will have authority over the research that's going up. So all research projects before they would go over there would come through my office, and I would have complete oversight on what is sent over. And then once it goes over, I will also have oversight as well as any other physicians that participate on the IRB board. So there will be JPS participation. And just to that point, if we do not form this entity, JPS would probably be forced to utilize a third-party IRB. And if we have to use a third-party IRB, we will not have any say or control on what happens during that regulatory process when we send our research off to a third party.
I think that, I disagree with that. I think if you do a third party, you can't have that party to come here. There are groups that do it. I'm just trying to clarify that if we have a collaboration, I can see this as a contract, but not as a collaboration, because you do not see, even with that oversight, if I can find my statement in the literature, is the final decision is made with the UNT. I'm just saying a collaboration should have some type in this write-up of how JPS fits in there. If we're just paying for staff, then it's a contract, it's not a collaboration. That's one of my concerns. If the other concern I have is that if, say this works and it's 100%, and I mean everybody is paying and the cost is defrayed, and there's a profit, what happens then? That's not there. Will we receive some? If you're doing a collaboration, I would believe that that should be a part of this document and this, whatever the other one. It is not there. My other concern that I have is it talks about this is budget neutral for UNT Health Science Center. And we will be picking up that, we show what we pick up. But then there's a clause in there that says any other additional costs, there might be some insurance costs. So I'm thinking, no, where's this collaboration? because it isn't in there that they would pick up any of that cost. It's kind of laid out, this defrayed cost is on JPS. So those are my concerns. I think that I would like to see it in the agreement, what's there. I believe it's a collaboration. If it's not a if it's a collaboration, I would like to see that. I'm still a little concerned that when you look at the organization structure, yeah, we have this oversight board, but it is totally right by UNTs. That's what information that I have. Those are my concerns on this. And even though it goes over there, JPS, let me make sure I have this. You would still be required to sort of have an IRB or something set up here so that you can review it and make sure that you're in compliance.
Yes, we would have a local team on site. It wouldn't necessarily be a traditional IRB board, but we would have research compliance here. We would review the protocols. We would send it over if it does need traditional IRB approval. And then we would maintain local compliance over that protocol once it is approved. Now, I do want to go back and address the oversight committee. So, yes, the president at UNT would be the top. However, all research protocol approvals would happen at the IRB board level, which is a combined board. So it would be a combined effort of approving those protocols. So we would have control in what is approved and what is not.
I do understand, and I'm not trying to make an exception with what you would be overseeing. That is exactly what it says. That's all you have any say-so over. My concern is it is not in this collaborative agreement that if it works and all of the stuff is done and there is some profit made, then JPS would receive its portion. It should be in here. I'm also concerned that you have an open statement with defrayed costs would be to JPS. And it is budget neutral. It says clearly it's budget neutral to UNT, and that any defrayed cost is JPS. I find that, I don't like that open statement. There's a statement in there about maybe looking at insurance risk. Who decides that? Is that what the, is gonna be made by UNT? And what response would JPS have except to say we want to get out of the contract? I mean, maybe that's, Alan, I'm looking for that in there. The indemnification is there. They are responsible for reviewing the protocol. JPS would still be on the hook for their liability to make sure that what they do is in compliance. We still meet all the rules. I understand that.
So that's, so my understanding of that is that JPS is going to cover their responsibilities that are happening on site at JPS. UNT is going to cover their responsibilities that happen on their side. And then I think that the Nortex IRB, the operations that meet there at the level of Nortex IRB, I think those liability obligations are shared equally. That's what my understanding is.
I got the one on the liability. Let's go back to the defrayed costs.
Okay.
I'm looking at one of the statements in there is they mention about additional defrayed costs that would come to JPS. Maybe I'm reading it wrong, but I didn't see that UNT was in this collaboration like an equal partner on those. Did I miss that?
I've not seen the term defrayed costs specifically being used, but operational expenses are to be, what I understand in the document, are what UNT has determined and budgeted what their operational expenses are for their IRB operations within Nortex IRB, and then JPS coming into this collaboration under this agreement, whatever operational expenses are attributable to JPS, then JPS will bear those.
Okay. Incremental funding is not required from UNT Health Science Center to implement and operate the Nartex IRB. And something I can't read, records, funding currently budgeted to operate the UNT Health Science Center IRB will be redirected to cover the cost of the North Texas. JPS funding specifically operating expenses of the North Texas IRB. Additional insurance may be needed to be purchased in order to cover the service provided by the Nortex. I'm saying, is that our expense?
That additional, that, based on that language, I would think that if that was an additional operating expense that was attributable to JPS's participation, yes, that expense could come through, but it's my understanding in the discussions with UNT that they agreed that for the 2-year term of this agreement, that's not going to change during the 2-year term of this agreement as the budget is set forth in attachment A to the authorization agreement. So the cost that's expressed at 325.5 roughly
Okay.
is you're set to for the next 2 years.
All right.
And then there's language in here stating that in 2.5 of the collaboration agreement that the amount of designated operating expenses to be paid by JPS as funding members shall be set forth in the authorization agreement between JPS and UNTHSC as may be negotiated from time to time. So it will be, can't change unless JPS specifically agrees to that in writing. And so that would be something that could be a negotiated point in the future. However, it would require JPS's consent.
Right. And the defrayment of cost would be when we bring in additional community partners to this entity, such as TCU, UNT, UTA, Parkland, possibly Children's Medical in Dallas, would all be additional entities we could bring in.
Have you looked at the potential revenue loss? Because when you do research, you cannot bill regular insurance on certain expenses that you incur, right? If it's a grant being conducted,
Right.
and have we looked at all that, followed through that process yet?
The revenue loss,
Potential revenue loss or potential compliance, so that we can stay within the revenue cycle side of it.
yes, actually, moving towards this collaborative IRB would increase our potential revenue as well as compliance.
How?
So right now, in September of this year, if you have NIH-funded research and you're doing research protocols, you are required to use a single-site IRB for multiple-site studies. So we would have to pay for either a third-party IRB, which would be a much more expensive endeavor than what this potential collaboration Nortex would cost us. And if we do not abide by the regulations, we would lose the advantage of actually participating in any of those NIH-related, so the National Institute of Health-related grant opportunities for research. So this would actually benefit us with respect to federally funded grant opportunities.
Do you, I think the question I've been always asking is, do you have the infrastructure for the clinical validation?
We are in the process of building the infrastructure. There has been some here, and it needs to increase. The advantage of this, of the Nortex IRB would allow us to increase the build of that infrastructure at a significant rate. So we would be able to hit the ground running and do more research projects quicker than if we did not participate in this collaborative effort.
Because what I'm worried about is that we built our system infrastructure for clinical care. And I don't think we built for clinical validation for you to have the ability to pull certain information to validate the patient condition, all that stuff, to see it all apply. And that could reduce the potential of a grant.
Will you repeat your question, please?
I'm just wondering if we looked at the infrastructure to do research, because you totally have to have different technology and platform in place for the clinical validation, those sort of things.
Yes, we do need to build the platforms for clinical validation, but the starting point is the ability to approve research projects efficiently and also to follow them compliantly. And the current state of the JPS IRB is not able to meet the demands that we would need to increase to result in a robust research program that could produce those types of evaluations.
Yeah, I think my question go a little bit beyond the IRB. It's the execution side of it that.
Yes, but once we have the IRB in place, then we can work on the execution of all of those clinical studies to produce the validations and to produce the papers to result in JPS's name being put on the map for research. But it does start with the IRB.
Mr. Chairman, again, I certainly concur with Dorothy's comments along the lines of, I think I wrote down, I read it, and I read obviously I certainly respect Dr. Costa's credentials at the table. The collaborative thing is something we just sat through a meeting this week with Commissioner and/or commissioners last week. I think this collaborative thing is something we're going to have to walk into a little bit of trust. We're getting a lot of push to get out and be collaborative, not only with UNT Health Science Center. We're sitting here looking at the TCU MD Medical School, and Dr. Zini and his committee is very involved, the educational processes and things there. We've now been asked to reach out to some other hospitals, private hospitals in this county. Again, I concur with Dorothy. I don't want to just be throwing money out and be the only person that's bringing money to the table and everybody else is getting a free ride. And I guess I'd love to know there's a huge upside here, and I would certainly hope our legal counsel would make sure that if there is, that we get something back for our expenses, time, and energy. I think if our exposure, expense-wise, is only to the tune of an insurance or something that we can define, I think a lot of work's been done. In fact, I think the first committee is chair of this board that was formed to look into things like this. I think you think the entire committee, and I do too. A lot of work's been done by this committee. That's the reason why it was set up, because these things are going to continue to come up. So, again, with all due respect, I certainly respect what Dorothy's saying. I'm just saying is this unknown or defined exposure is what seems to be, if there's an issue, it's not in the practicality of the IRB or what research is going to get done. Is that, Dorothy,
That's part of it.
I know that's part of it. Is it?
That's part of it. And I guess collaboration is a term that we want to use. And I don't have any problem with collaboration. If our collaboration means we're always the payer, so be it. But that's what this is to me, is that every time we have a collaboration, it is JPS has to put in everything for this collaboration to occur. That's one concern. Number two, if we are saying here that we are not ever going to try to look at, it's going to outsource it forever. We are not trying to learn to do anything ourselves. The single IRB said it was going to be in effect 17, is not going to be in effect to 2020, so it isn't any rush on that. Right. I think that even when you do an IRB that we're talking about, you still have to have all those same deals in place at your facility.
In my opinion, and again, with great due respect to you, Dorothy, I think this opens the door for us to create those efforts. I think you're going to get, I feel confident with TCU and UTA and some of the others. I cannot speak for them, but I think once this is established, you're going to see others that come to this. And I think JPS takes the road and we clear that path. I think this creates a possibility with the TCU Medical School when it comes on board to show our efforts to try to create these. And I know that I have heard historically some concerns from others in the community that there needs to be a different process than one we had historically had, and I think this opens the door to do that. So I think you're going to see positive changes, and I think this will get us there. I think it opens the door, and then I think you're going to find your UTAs and your Parklands and your Cook coming to this table.
Okay.
Could you help me? Because I'm struggling with this. I've been a proponent of research for as long as I've been on this board. I think we need to go down that path. My challenge is that I only see a linear road. I don't see the roadmap. I don't want to dress up and no place to go. Help me.
We're trying to get you Uber right here. Get you over there.
Right, it's just like, we're gonna have all this, where are we going next? When are we taking the next step? Because I've seen, we get ready, but no place to go. We just dress up, no place to go.
Yes, well,
And it just like, I understanding of the process, that's why I said, help me here.
it is a process. So once we have this established, it will make doing collaborative research easy, because there's one IRB that everything is approved through. So you have one protocol, you submit it to the IRB. Once the other institutions join in, we can have a research project at JPS in collaboration with UNT, in collaboration with TCU, in collaboration with Cook Children's. So then it becomes a Fort Worth community research project, and we can pull the creative minds of that physician community and really establish well-sounded research that can be published in a very high-impact journal that gets picked up by the Associated Press, and JPS's name would be on that. So that is when we get dressed up when we're going out.
If I could-
For me, I'm still looking at, build and they will come. I need a little
It
bit
is.
more, because it's almost like a license to hunt. And help me get to the next roadmap. Because if we don't have the right infrastructure, I know we have the right patient mix, we have the right clinician, I think we have the right clinical people here, but it's still some missing element that I don't see, that I can't connect the dot yet.
The missing element is the ease to do a research project. In our current infrastructure at JPS, if a physician comes to us with a research proposal, it could take us almost a year to go through the entire process to get them the approval so that they can actually start their project. And by the time that starts, they're frustrated and they don't want to do it. By
I have a
increasing our regulatory process and making it more efficient, then we can get those off the ground quicker.
I may have a different view on that, because I think we try so hard as an academic environment to get the poster out there. But the poster have to back up to see how quick you get to the people who qualify for it, who has this condition, and who fit these criteria. That's why I've been asking for the clinical validation. That way you can attract bigger player in the market to fund those initiatives. And that will require infrastructure, technology in place to pull, because if you're 1 month or 2 months behind, UT Southwestern will win every single time.
Yes, they will.
That's what I'm trying to get, is that where are we going?
So by the ability to efficiently review research protocols, we can compete for those clinical trials that pharma or medical device companies, that they need a patient population such as ours. Right now, if they come in and they want to do a clinical trial at JPS, it takes too long for us to get that protocol reviewed. So we lose out on that funding as well as that research that is being done.
Are you looking at building the infrastructure after you get the team built? Are you looking at a year down the road, 2 year down the road? how do we
We're building
coordinate?
simultaneously. So I've currently started building an infrastructure to bring in additional clinical trials and other research projects, along with the build of the IRB, the Nortex IRB.
Because I haven't seen, because I've been one of those, that so we can give you the money to spend on infrastructure. I haven't seen it, that's why.
So I'm still working on that. I have been here for 90 days. So I'm starting to put my team together.
Isn't that what we're asking her to do?
Exactly.
Just develop the infrastructure? I mean, that's how I look at it.
Well, if we're asking her to develop the infrastructure, is the infrastructure here or somewhere else? That's the question I'm asking. And I won't belate the discussion. I know that we've collaborated and have studies done here with other entities and doctors before. It isn't like, oh, we've never done any of those. We have. So I know that has occurred here. I think we do have some holes in our process, and it's not automated. I'm aware of that. I'm just not sure that having this as for stopgap measure is one thing, but I'm concerned about long-term. If you're saying we're building our infrastructure, okay, well, if we're building our infrastructure, but I'm building it over there, or am I building it here? I see this, what we're calling collaboration, as no more than a service contract, and that's how I view it. And we've gone to someone, here's what we get, and here's what we're paying for. And then if you're doing that, that's fine. But I would think that if you are a hospital that have residents, that you would have something built in your own system so that you can do it. Single IRBs have been a discussion for a long time, and they haven't moved. There are pros and cons against all of them. I just would say that whatever we are agreeing to, totally, it should be in writing in this contract. These agreements and amendments, authorization, have some holes in them. And I'm aware that if it isn't there, that's all you're going to get.
I do have one other comment I want to make following up on the whole clinical evaluation of our data. Dr. Rohit Ojha is the director for the Center, the Center for Clinical Outcomes. And his group, they are a group that they're currently looking at all of our data, and they're developing roadmaps for funding, and they're working on outcomes papers relating to our data. So that information is starting to come, bringing in epidemiologists and biostatisticians and putting them together and developing working cohorts. So they're developing working groups, working with our data. And that data will feed into the clinical research group, and we'll be able to attract bigger research projects and other additional funding.
Dr. Costa, I want to thank you for coming to your first meeting. I know you look forward to your next meeting.
Right.
So.
They get harder.
So
I'm gonna-
We want to give you the easy one.
And I want to say thank you for your input. I'm not beating up, not appearing to, don't want you to think I'm beating up on you, but I do want to, you to understand that I supported us moving forward with doing the research. And when it started with Shafi, and the plan for that was to come back. Part of my frustration is it hasn't ever come back to this board. And now we're moving on something else, and we have not laid out that roadmap. We put dollars there, but I don't know how many dollars now. So we said, okay, that's a good idea, and we've heard nothing else.
Okay.
And so that's partially what you hear, okay?
That's fair criticism.
It is her charge to develop the infrastructure. I mean,
So I appreciate the comments and the concerns that are well expressed. I'm going to exercise the chair's prerogative and call the question. And so I would entertain a motion.
Approval.
We have a motion by Dr. Weber. Do I hear a second? Second by Mr. Powell. All in favor of the motion, please say aye.
aye.
Opposed?
Aye.
Clearly. Mr. Wynn, are you aye or no?
No.
No, okay, we have
More
two.
roadmap.
4 ayes and 2 noes, the motion passes. Thank you very much.
Go to Cooperstown. He just drove through Houston.
I think that DT's and Dorothy's comments were very valid.
Absolutely.
And that's
I agree.
something we would be looking at as
I agree.
this, I look at this as the first step, so.
I think your comments are well taken, and I agree.
Mr. Chairman?
Yes, sir.
I had my hand up before you decided to call for a vote, so I'm not going backwards here. I just want to make a statement as chair of the board. Sometimes these conversations, we're not always going to agree on everything. But I want to make sure I don't want any misconception here that this is one additional tool that JPS will provide, be a part of, as part of collaborative actions in this community, and hopefully there'll be more. I certainly agree with Dorothy. We don't want to be the ones that's always paying and always seem like we're not. I don't want to look at everything we do going forward to have that overhang that we're not going to get dealt with. But I think this committee needs to know it, and the board will be told the same thing. Comments today that have come up, and this is nothing more than it's going to go to the board, is that this is no way that this is a negative because we don't think we can do it here. I think it's a timing issue, like DT pointed out, or Dorothy's talked about. We certainly looked at our own. It's not that we question or limit the capacity of our excellent staffs to do all this internally. This is nothing more than a collaborative effort to see if we can move along and then bring that, hopefully, Dorothy, like you say, back in-house. So, again, I just want to make that point. You know, sometimes you go do things because you don't think you're capable of doing it. I certainly don't want that image to be a reflection of this institution. That's not what this is about. So, thank you for
Understood.
your comment.
Thank you. We're going to move on to item F. Consider approval of professional services agreement between Related Care and Tarrant County Hospital District. Good morning. It's still morning for another 7 minutes.
Thank you for having me here today. The contract that you have before you is for approval of a professional services agreement between Relate Care and JPS, or Tarrant County Hospital District, for the approval of an after-hours nurse triage advice line and access call center. This is actually replacing a current vendor that we have. We anticipate savings over the current vendor that we use with an increase in service. This vendor does have Epic access, and what that does is actually allow them to take the call and schedule appointments within our primary care clinics as needed, and so that does help us with call volume coming in the morning when the nurses arrive in the morning, not having a backlog, and also not sending patients to our ED.
Okay, you've heard
Any
the
questions?
description. Any questions? Okay. Entertaining motion for approval. Motion by Dr. Weber, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you.
Thank you.
Wanda, item G. Oh, you're up here for a while, I think. It's the Wanda show. Hope you brought a lunch.
We just made it. We're always ahead of our time.
Actually, it looks like I'm gonna spend the afternoon, so this will actually be very brief, so.
Could you turn your mic on, please? Thank you.
Items G through L in your packet for hospice care are all the same agreement. They are all duplicated. However, what happened here was we sent our contract out it was up for renewal, so we sent it out, did an RFP, and got several responses back. We're required to have multiple sources for our patients to pick from, so we do partner with several different entities for hospice care. So the contract is for all of these different services: Kindred, Serenity, Vitas, Community, Hospice, and Covenant. This will save us, or these contracts are in the budget, and estimated to be about $620,000 annually. When we put it out for RFP, we looked at all the responses that came back, and we had a committee that looked at these responses, and we only went with companies that were 3 and 4 stars and made sure that they were all Medicare certified. So there was a committee that selected this group of vendors, and so we are asking to approve this contract
Okay.
for our hospice.
Well, because the lawyers are here, we have to take each one of them, so. but-
We have to take each one,
Yeah.
okay? So the first one then, G, is for Kindred Hospice Care.
All right, so we have a motion by Dr. Weber, second by Mr. Powell. All in favor, please say aye. Aye. Motion's opposed, motion's approved. Item H,
Serenity Hospice Services.
entertain a motion. Motion by Mr. Bose, second by Mr. Nguyen. All in favor, please say aye. Opposed, motion passes. Item,
This is for Vitus Hospice Services.
are you an I, is it a I or H or I? I lost my spot.
H is
We
Serenity,
just did that one, so I.
and I is Vitus.
Vitus.
So moved.
We have a motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye. Opposed, motion passes. Item J,
J is Community Hospice of Texas.
entertain a motion.
Move approval.
Motion by Mr. Bose, second by Mr. Powell. All in favor, please say aye. Opposed, motion passes.
K is Hospice Health Care Network.
Motion by Mr. Bose,
Second.
by Dr.
And
Weber.
last but not least
All,
is,
sorry,
Oh, I'm
all in
sorry.
favor, please say aye.
getting ahead of myself.
Opposed?
I'm
I
excited.
like your pace, but that's, motion passes. Item L,
Covenant, Hospice and Palliative Care.
entertain a motion.
Move approval.
Motion by Mr. Bose, second by Mr. Nguyen. All in favor, please say aye. Opposed, motion passes. All right, thank you. Now you're up for,
Okay. Next is item M on your agenda, and this is approval of an agreement between United States Endoscopy, and this is for our endoscopic accessories that we use in the endoscopy department, such as forceps, tubing, stents, disposable valves. And basically, this is just giving us much better pricing by doing a 3-year agreement with this company, and also saving us the cost of inflation, that we took that 3% off.
you're satisfied with their performance and, so.
Pardon me?
You're satisfied with their performance, so 3 years is a good.
Yes, we
I
are.
like
And
it.
we get almost all of our accessories for this company. It's just giving us better pricing for this.
Great question. Is it same equipment as what we're looking for a longer agreement? Is that what it is?
Yes, sir.
Okay.
Yeah, so we're not changing anything. It's just
Yeah,
our,
the equipment's fine. I just, if we're gonna change, then
no, we're not changing anything. It's just getting better pricing.
You got me there. All right, I'll entertain a motion.
So moved.
Motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed, motion passes. Wanda, letter N, and you'll be here right before noon.
Okay, this is for, this was included in our capital budget for this year, and this is to get a new neuro microscope, a Carl Zeiss microscope. One of the microscopes that we currently have frequently goes down, and we've had to end up canceling cases or delaying cases by only having one microscope in the OR. So by getting this new microscope, we'll be able to do more than one case at a time. The current scope that we have that we're asking to replace has been sunsetted by the company. We do have a letter from them stating that, and we can no longer get parts to repair it. So therefore, we're asking to replace this item.
All right, you've heard that description. Any questions for Wanda on that item? Motion by Mr. Bose, second by Mr. Powell. All in favor, please say aye. Opposed? Motion passes. Thank you, Wanda.
Thank you.
All right, there are no items enclosed for legal or otherwise, so we are adjourned.